Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
Hello, this is Dr. Ted Rosen, editor-in-chief of Dermatology Digest, with another edition of Let's Get Lit. We'll talk about some new literature. So let's dive right in with atopic dermatitis. No surprise, in the December 2024 issue of Pediatric Dermatology, there was a big retrospective database analysis showing that pediatric patients with atopic dermatitis that was not well controlled, persistent, or associated with comorbidities, those folks were particularly likely to be allergic to peanuts, eggs, and milk. No surprise. We know that food allergies can go along with atopic dermatitis. This was just a giant retrospective analysis. In the online December version of the journal Dermatitis, there was an interesting article about a subject we don't talk very much about. This was an analysis of a young adult Canadian atopic dermatitis cohort, and they said that their disease severely and adversely affected their sexual well-being. Almost 80% felt unattractive, 70% felt embarrassed, 70% avoided sexual activity altogether, and almost 60% had experienced rejection. After a year's worth of treatment with either a JAK inhibitor or dupilumab, those perceptions dramatically decreased or even disappeared. So remember that along with all the other problems associated with atopic dermatitis might be a severe inhibition of sexual well-being. In the October issue of Dermatologic Surgery, there was an interesting article. I don't know how true this is of the entire United States, but they did a standardized interview with 63 medical spas. And the interesting thing that they found, over 70% of injectable treatments, toxins, fillers, deoxycholic acid, were performed by non-physicians. But I think even worse, with regard to these same medical spas, a supervising or service providing physician was present in only 38%. And even more disturbing, about 40% of such facilities did not have a phone number for patients to call in case there was a problem outside of routine business hours. So I think you just need to think, if you're associated with a medical spa, that it's being done right and in the most safe manner. In the January 2025 issue of Dermatologic Surgery was a nice article looking at a database of nearly 4,000 patients, showing that Mohs micrographic surgery resulted in longer, disease-specific survival compared to wide local excision with regards to malignant cutaneous adnexal tumors, sebaceous adenocarcinoma being the most common tumor encountered in this study. In the December 2024 issue of JAD Case Reports, there was a nice case report that illustrated a phenomenon, frankly, that I was not familiar with. If you're looking at someone with a widespread erythematous, maybe a little scaly, maybe a little atrophic eruption, you know what I'm talking about, where you're thinking maybe this could be mycosis fungoides, they pointed out and illustrated beautifully the notch sign. if the red scaly atrophic area is interrupted by a notch of normal skin entering into it, that isn't diagnostic of, it's not specific for, but it's highly suggestive of cutaneous T-cell lymphoma. In the December 2024 issue of the Journal of Drugs and Dermatology, there was a nice case control analysis using the All of Us database, a very large database, that showed that metformin was associated with a decreased risk of non-melanoma skin cancer. So maybe for those people who take metformin, mostly for diabetes, there's a silver lining to the cloud in that it may reduce your risk of non-melanoma skin cancers. There are multiple mechanisms they went over explaining why metformin might be protective against skin cancer, but nobody really knows for sure why. In the January 2025 issue of the International Journal of Dermatology, there was a comprehensive meta-analysis performed on all randomized, double-blind, placebo-controlled studies of JAK inhibitors, all of them, for dermatologic indications, both on and off label. So this was a giant study. And they found, happily, that there was no increased risk of serious or opportunistic infections in JAK recipients for dermatological indications. That was compared to matched placebo control patients. Now, JAK administration in derm patients was associated with an increased risk of varicella zoster, shingles, as well as herpes simplex infections, but no major serious infections. And that's very reassuring. In the January-February 2025 issue of the Indian Journal of Dermatology, Venereology, and Leprology, there was an Indian prospective study that found the addition of narrowband UVB to systemic steroids was the best overall response for generalized lichen planus. And they compared that to systemic steroids when dapsone was added or azathioprine was added. Narrowband UVB was the best thing to add. And every once in a while, we do have generalized lichen planus, and you have to do something systemic. You can't really treat that topically. Speaking of lichen planus, in the April 2025 issue of the Journal of the American Academy of Dermatology, there was a nationally representative Explorus database assessment involving 567,000 patients looking for lichen planus. And it turns out only 0.19%, less than 0.2% of the study population of 567,000 individuals developed lichen planus. So it isn't very common, but of course can be very much a nuisance when it does occur. There was a preferential occurrence in women older compared to younger individuals and those of Asian ethnicity. Topical steroid monotherapy was used in 76% of all individuals. I guess if it's fairly limited, that's a reasonable thing to do. But keep in mind, the last paper I just talked about from the Indian literature, generalized lichen planus, you really can't treat topically. You need systemic steroids and narrowband UVB or some other agent. In a recent issue of Skin, the Journal of Cutaneous Medicine, there was a comprehensive review that offered what I felt was pretty compelling evidence that generalized pruritus in the absence of any skin abnormality, isn't that a common problem? Most of that's dry skin, of course, but they found that that may be due to iron deficiency, and when that is the case, the itching resolves with repletion of iron stores. And in a patient who presents with generalized pruritus, I don't usually check serum iron. That's not one of my things. So this paper is going to alter my standard operating procedure. In the January 2025 issue of the Journal of Cosmetic Dermatology, there was a retrospective study from Turkey regarding seborrhea. And they said seborrhea was correlated with a, quote, poor, unquote, diet, namely eating few fruits and vegetables, but eating more margarine, animal fat, and sugar, and that a higher body mass index was also associated with seborrhea. So someone with really bad seborrhea, think about some dietary alterations. In the February 2025 issues of the Annal of Internal Medicine, they talked about the commercially available agents, liraglutide, semaglutide, and tirzepatide, used to reduce weight. And of course, some dermatologic diseases benefit from weight loss, or they become easier to control following weight loss. And they said that all three of those agents induced real, significant weight loss. But they did point out that at the doses required to induce weight loss, there was a risk of predominantly gastrointestinal side effects, nausea, vomiting, diarrhea, or constipation. I'm not sure if we should be prescribing those. There have been some who have advocated that, but even if we don't give the drug, if we think that weight loss will benefit somebody's dermatologic disease or make that disease easier to manage, then I think we should feel comfortable recommending that as something that might be done under the control of the primary care providers. In the January 2025 issue of JAMA Dermatology, there was a consensus statement regarding low-dose oral minoxidil. How do you define low dose? Some say it's 2.5 milligrams or less. Some say it's 5 milligrams or less, but it's low dose. And I think the interesting thing about this consensus statement was that low-dose oral minoxidil appears to be beneficial for many types of alopecia, including androgenic alopecia, alopecia areata, telogen effluvium, traction alopecia, chemotherapy-induced alopecia, and endocrine-induced alopecia. The panel of experts who made this consensus statement suggested that starting doses should be 1.25 milligrams a day for adult women, 2.5 milligrams a day for adult men, and half that amount for adolescent boys and girls. There are some contraindications, and we should be aware of those. That includes congestive heart failure, any pericardial disease, pulmonary hypertension associated with mitral stenosis, pregnancy or lactation, and pheochromocytoma. In the January 2025 issue of Clinical and Experimental Dermatology, using data collected from the All of Us database, adults with congenital ichthyosis were found to be at higher risk for some infections. Those included warts, tinea pedis, and tinea corporis. That was compared to control matched individuals. The study included 2,260 patients, so pretty decent size, but unfortunately was only adults. They didn't look at pediatric patients with congenital ichthyosis. So that's still not known. I found very interesting in the March 2025 issue of the Journal of Dermatology, an analysis of a Korean nationwide cohort of 4,976,000 plus. That's nearly 5 million patients compared to a comparable matched control group. Those who experienced COVID-19 subsequent to their COVID-19 compared to those who didn't were at increased risk for eventually chronic urticaria, vitiligo, alopecia areata, and herpes zoster. Does the COVID-19 somehow alter the immune system to express these diseases? We don't really know, but this was a huge analysis. And so chronic urticaria, vitiligo, alopecia areata, and herpes zoster may be increased in those who've had COVID-19. In the April 2025 issue of Journal of the American Academy of Dermatology, there was a retrospective evaluation of patients with Becker's nevus, and they disclosed unrecognized risks for neurologic, endocrinologic, and oncologic abnormalities. Most notably, 38%, so a little over a third, of those with Becker's nevi demonstrated neurologic or neurocognitive disorders, such as epilepsy, attention deficit hyperactivity disorder, and autistic spectrum disorder. Very interesting in Becker's nevus patients. In a relatively modest-sized Chinese study published in the April 2025 issue of Dermatologic Surgery, they pointed out that deliberate sleep deprivation enhances chloral hydrate or local anesthetic effects during pediatric cutaneous surgery. So if you know you're going to do surgery on a child, I would say probably it's good for adolescents too, although that wasn't really the focus of this study. Keep them up the night before. Have them tired. And then a little bit about rheumatologic diseases to close this issue out. In the October issue of Arthritis Research and Therapy, there was a validated measurement of skin thickness that showed that reduced cutaneous fibrosis following therapy was associated with preservation or improvement of pulmonary function. And the converse was also found to be true, that declining pulmonary function was associated with worsening cutaneous fibrosis. So maybe measuring the skin can give you an idea about what's going on in the lungs, although it's pretty easy to obtain pulmonary functions. And then the last article I thought was absolutely fascinating. We need some additional data along these lines. But in the December 2024 issue of Arthritis and Rheumatology, they did a prospective study where they put mupirocin ointment on lesions of cutaneous lupus for 1 week. And they found that they lowered the lesional colonization by Staph aureus. And they compared that to putting Vaseline on cutaneous lesions of lupus, which didn't alter the colonization of LE lesions by Staph aureus. Now, by itself, that doesn't matter very much, I don't think, but what they also looked at was lesional upregulation of the interferon pathway, signaling and inflammatory gene expression, as well as the localization of cutaneous monocytes. All of those also decreased in the lesions of LE that were treated with mupirocin for 1 week. And we think of the interferon pathway and inflammatory gene expression being very central to the etiopathogenesis of lupus erythematosus. This study suggests that a topical antibiotic like mupirocin might be employed to decrease cutaneous lupus skin inflammation by reducing resident staphylococcal colonization. And wouldn't that be a nice addition to treating without a systemic agent with something we all use routinely and find relatively benign, topical mupirocin ointment? So stay tuned. That was a very small study, and obviously it will, I think, make someone else do a very large study to verify that and expand those findings. So I hope you found something interesting, intriguing, possibly even might alter your standard practice patterns in this review of the literature. And stay tuned for our next edition of Let's Get Lit. I'm Ted Rosen, editor-in-chief of the Dermatology Digest. Thank you for listening.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.